Hello and a very warm welcome to this NOI Group clinical discussion. My name is Joanna Taylor and I am Director of NOI Group Europe. And I am joined this afternoon by NOI Group teacher and my very good friend, Laura Rathbone. Welcome back, Laura.
Hello.
For those who missed our last session, Laura is a respected pain specialist clinician and mentor to health professionals worldwide. She brings she hates it when I say that, I know she does. She brings a unique perspective, combining cutting-edge science with compassionate and inclusive practice. Laura, it's so great to have you back. Could you just give everybody a little idea of what you're doing currently at this moment professionally, please?
Right, yeah. Oh my God, I just have to say someone's from Blackpool. All right, love. Sorry. It's been so long since I've been in Blackpool. Okay. Anyway, back on track.
Love it.
Um, I'm a specialist physiotherapist. I work in complex and chronic pain. I work psychologically informed by acceptance and commitment therapy and trauma informed. My current clinical role is as a consultant, pain consultant in physiotherapy to the OLVG hospital here in Amsterdam, where I work inside their pain team, which I just love to be there. And I've also been facilitating trainings in acceptance and commitment therapy for non-psychologically trained therapists and clinicians for about 8 years now. So I've worked with lots of people across the multidisciplinary, some psychologically trained therapists, but I mostly aim my work at those who haven't been through a psychology degree. Um, in their sort of working in this other area where we're trying to be careful of our scope, which is why this conversation is really interesting today. But in addition to this, I'm a clinical educator, I'm an activist for social justice in pain care, and together with my friend Christine Petridis, I run Pain Geeks, and I'm going to drop
Mhm.
the link into the chat. Pain Geeks is an international and multidisciplinary reading community where we focus on deepening our knowledge about this experience of pain. So we read widely across the landscape of evidence, from sort of basic science to expert opinion to humanities to you name it. If it's about pain, we're probably interested in it. And we're also looking at supporting clinicians to develop their critical reading skills and academic skills so that when they are reading something, it's worth their time, first of all, and they know how to get the most out of it. So, because there's a lot out there and it's quite tricky. And the focus is on community. So we spend a lot of time meeting in real time to discuss what we're reading. So that's Pain Geek. So you can go and have a look at that.
Thank you. Yeah, do go and check it out. It's a really, really vibrant community that Laura runs, and it is amazing. So please do check her out in there. So these sessions are all about giving you a taste of explained pain and how to practically use it in the clinic. Some of you will have already done an explained pain course, and for those of you who have, these sessions are designed to reinforce what you will have already learned. But if you're new to Explain Pain or new to NOI, this will give you a taste of what we cover in the Explain Pain course and a taste of what NOI is all about. Now, Laura has a couple of courses upcoming, an online one in October and a face-to-face one in Dublin. And we'll be talking a little bit more about those at the end of the session. So if you're interested in doing some Explain Pain education with Laura in whichever format, then just hang around at the end and we'll tell you a little bit more about those. So Laura's going to be talking for about 20-25 minutes. If you have any questions, please put them in the Q&A or in the chat. I'll be monitoring those and we'll get to as many of them as we can. If you have a question, I'd urge you to get it in early because we always run out of time. If you want to watch the recording of this session, you can access it in the clinical discussion group on YouTube. And also, I just want to give a shout out here to David Bolton, who is in the audience today. He runs the Facebook clinical discussion group, which is absolutely awesome. So I'm going to drop those links in the chat. Please do go over, join the Facebook group. It's very, very active. There's great content in there. There's loads of other clinicians to talk to connect with, and the YouTube channel, which is where we put the whole library of these sessions. So please go and check those out. So without further ado, today we're talking about pain education. Oh, no, sorry, that's the wrong one. That was last week, Laura. I need to scroll down.
We're
Bear with. We have
yeah.
we keep a record of what we've done.
Hmm.
So
Yeah.
today we are talking about, oh, so exciting, creating psychologically informed pain practices. So can you tell us what you're going to talk about this afternoon?
Yeah, okay. Well, I think we're going to try and cover a little bit about what does it mean to be a non-psychologically trained clinician that's able to recognize, the emotions and cognitions and thoughts and I guess psychological factors you might say in your patient, and how do you hold that safely within your scope. We're also going to think about how acceptance and commitment therapy, particularly because that's my bias, can underpin some of your explain pain approaches or some of your sort of pain neuroscience education choices, I think is what I would say. And then, what do you do when you see trauma responses in the clinic? How do we hold those safely? And I just want to really preface this by saying, you know, you're not going to get enough from this session on any of those topics, right? So this doesn't make you all of a sudden have the capacity to widen your scope into being able to hold psychological trauma. But it's just a very small advisory introduction to noticing what's happening around you, and maybe even finding new and other resources to further that development. So I just want to be really clear about that this is not a training in those things. It's just signposting towards what could be useful.
Okay, thank you. Thanks, Laura. Thanks for being so upfront about that. These sessions are a bit limited because of the time.
Mhm.
Okay, so let's start with something that many clinicians struggle with. How do you recognize when psychological factors are at play in someone's pain presentation without overstepping your scope of practice?
Yeah, this is great because I think what we're saying is there's a difference, right? So I want to just be clear about this, and I might not get this out very clear today because I'm a bit sort of befuzzled today.
Well,
But like you're always seeing psychological factors when you're in the clinic. If you're working with pain, you're always seeing that. And we know that because our definition of pain very clearly says that, right? So if you go to the IASP terminologies page and you look up the definition of pain, it says an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Now, we could spend hours dissecting all of the limitations with that definition, right? But that definition was brought about, it's obviously been updated since the 70s for a very specific reason, because there was a feeling within the pain system in the 70s that we were being overly reductionist towards sort of like tissue-based ideas and causation when it comes to pain. So they wanted to make sure there was a definition of pain that honored the fact that pain was always coming with psychological experiences, right? It's an emotional experience. And that is the biopsychosocial framework, right? It's not that there is this thing called pain that's affected by all of these things. Your pain is a representation of your biopsychosocial experience in the world. So you're always seeing them. So we're always working in the psychological field. It's just that we're not necessarily always trained in how to label those things that we're seeing and how to work with them. So I think the way that I would suggest to patients who are not psychologically trained is to, like myself, I'm not a psychologist, to look for patterns in behavior rather than trying to diagnose conditions. So we can sometimes fall into the trap of being like, oh, that must be anxiety. Well, anxiety is actually a diagnostic term that you don't necessarily have the scope to use, right? But you might be able to show rigid thinking, all or nothing thinking, rules-based living, distress, resistance, lack of connection to values, low behavioral activation, financial insecurity. You might be able to label what you see rather than diagnose what you think it all means. And that can just be one way of starting to support your practice and name what you're seeing in the world. And I think we've been doing that for a while, right? I remember when I was younger, there was this sort of yellow flags assessment that can be a really helpful first step in just labeling what you're seeing in front of you. I think that can be quite helpful. And I think that sort of stops you from moving into outside of your scope, which is that sort of clinical diagnostics realm. And noticing the relationship between, tissue loadability, let's say, so a person's ability to load, whether and their pain experience, and is there a sort of, are we seeing lots of pain when actually the person's sort of physical body is quite safe to move. That
Mm.
would also be an indication that something is going on there. Um, and observing how and sort of opening up the discussion to observe how pain might change depending upon context, depending upon psychological stress, like, and also if you've not slept very well, all of these things can help a person recognize that pain isn't just a sort of one-to-one sensory relationship with your tissues. It's a much more complex experience that can move and shift and change depending upon where you are, who you're with, and how you feel. And I think
Mm.
these are some of the ways that I work with patients without drifting across into um, or outside of my scope. So you have to know what your scope of practice is
Mm.
clearly and what your
Mm.
boundaries are. Yeah.
That was great, Laura. Thank you. Really, really easy to understand. So you've mentioned ACT principles.
Mhm.
Could you give us some examples of how clinicians may use these principles in pain consultations?
So for anyone that's never heard of acceptance and commitment therapy, ACT is like a third wave cognitive and behavioral approach to therapy. So cognitive and behavioral therapy has been on a bit of a journey since the turn of the 1900s that not
Mm.
everybody knows, but I think most people are aware of. Like we went from sort of like psychoanalysis, then we went into behaviorism and cognitivism, then behaviorism and cognitive neuroscience, and we're sort of moving through these evolutions in the way we deliver cognitive and behavioral therapy. And acceptance and commitment therapy is just a sort of a more recent evolution of that. It's what we call these process focused therapies. It's not so much focusing on teaching people how to change certain thoughts or certain behaviors. It's more thinking, well, what's underpinning the reason that we've got stuck in the first place. So within acceptance and commitment therapy, we're trying to promote this process of change called psychological flexibility. So
Mm.
that's the main process of change that we're working on. And that really just means doing things differently in order to make life richer and better. That's really what we're trying to look at. And we use a skill set that's sometimes called the hexaflex of different sort of skills that can help somebody move towards doing things differently. So we call this willingness, diffusion, present moment awareness, self as the context, values, and then commitment to action. And these sort of skills that all these skills, six skills, can support someone in developing more psychological flexibility, particularly when they're experiencing avoidance or resistance.
Mm.
So, the way that we might apply that in a more practical sense is we might be really focusing on helping people understand, first of all, what is a value and what is a goal, and then how do we make a values-based goal. So we're trying to be very clear and about shifting the focus from achieving stuff or not being able to achieve stuff to figuring out why achieving things is important. Why is it necessary? What does this mean for
Mm.
you? Um, and then, so that's these can take multiple sessions, right? So don't rush this because it can take time. And in order to get there, sometimes you have to expose someone to the self, right? And that's what we call mindfulness. So present moment awareness, mindfulness, this is just sitting down and observing yourself in the moment and being like, whoa, I didn't know that my mind did that. That might not be always be super helpful. And so we're using that observation skill, we're building that observation skill so people can notice where the opportunities for choice might start showing up for
Mm.
doing things differently, right? That's psychological flexibility. Um, and ultimately, the really important thing about ACT is that it is very much a doing process, not just a thinking and talking about doing, right? So we're really looking at trying to walk the line with patients, get into those experiential pieces of work, which is where like I think clinicians that are body based or exercise based really have like the advantage in many ways because we're really good at prescribing movement and activity. And what we need to sometimes build up on is that cognitive skill set around sort of like getting comfortable with what the person is thinking and feeling at the time.
Mm.
So I think for us, acceptance and commitment therapy can be a really easy transition for us.
Mm.
Yeah.
Brilliant. I love that. Walk the line with patients.
Yeah, it's
Great.
key.
Yeah, nice quote.
Yeah.
Okay. Thank you, Laura. Quick question from Yasmin. How do you navigate hope in the context of acceptance?
Love it. Wherever it is. Great. More of it.
Hope.
I mean, the problem we have to be careful is that the hope has to come from the patient, right?
Mm.
Can't be us forcing it on them. It's got to come from them. And hope isn't something I can give someone. It's something that needs space to bloom, right? And in the very beginning, it can feel very fragile and very delicate. And we want to, but we absolutely need hope because hope is is a sort of, it's a partner of agency. So you can only have hope if you believe you have what you need in order to make a change. You believe that the change is possible. Otherwise, that's just wishful thinking, right? That's like a thoughts and prayers kind of approach, right? We're
Mm.
thinking about real hope is being able to look forwards, being able to see a future, being able to imagine the steps of change. But I can't push that onto someone because what I'll end up doing is actually just smothering their own hope that might be just a tiny little baby process that's starting to flicker. So for me,
Mm.
it's really about, it's like with everything, reassurance. You can't give reassurance. People have to have space to feel reassured, right? That's the sort
Mm.
of thing we have to sometimes give space to. Compassion. I can't give people compassion. They have to
Mm.
allow their own compassion to grow. Sometimes my trick is to just get out of the way of that and step back and be like, what do you think we can do next? What do you believe we can achieve? And try to support
Mm.
them to figure out what their next step is as much as possible. And there's nothing more wonderful than seeing someone come through who's hopeless start to build hope. And
Mm.
it's actually a real kind of, you've got learned helplessness, but then you've got creative hopelessness. That's the process in ACT, right? So we're trying to move people from a learned helplessness place where it's like, there's nothing I can do about this. I've got no agency, no power, no hope, into a place of, well, if there's nothing I can do, I've got to do something. What can I do? Right?
Mm.
And that's that creative sort of like hopelessness. Like this is hopeless, so I've got to get creative. And then what's really beautiful and really interesting is people start to actually sort of flex their hope muscle again. They start to build that space out again.
Mm.
And
Lovely.
I think it's necessary. Yeah.
Yeah. Thank you. Thank you, Yasmin, for the question.
Yeah, lovely.
Yeah, nice question. Okay, so we're going to try and cover everything today. So keep going, Laura, keep going.
Yeah, yeah.
So this is a big one.
Okay.
But how do you work with trauma responses and emotional overwhelm when they show up during pain consultations, especially when you're not a mental health specialist?
Yeah. Okay, so this is really about safeguarding people. Okay, so if somebody's having active flashbacks, so if they're in like a PTSD, an active PTSD state where they're disassociating from their present moment and having very invasive flashbacks to something that's happened in the past, that is an unsafe moment for this person. Now, what do we do in that moment? I can't magic up a psychologist, right? So but I absolutely, at that point, if somebody's experiencing that, I'm not working with that. As in, I may still continue to work with the patient, but I can't
Mm.
work with the active PTSD because I don't have that training. And that's where your relationships with local psychologists and psychotherapists who are trained in EMDR or trauma work. And remember that there is an EMDR for pain, protocol for pain, for chronic pain. So do reach out to your local
Mm.
psychotherapists who are doing EMDR and see if they've trained in that protocol and if they're
So what
comfortable with it.
EMDR? Can you just say what that
Oh
means?
my God,
Sorry.
I don't even know what it stands for anymore. I'm going to Google it. EMDR.
Quick Doodle.
Eye movement desensitization and reprocessing. Okay,
Okay.
so there's loads
Well,
of questions around the actual process that's happening, but it can be a very helpful therapy for people with trauma. It's one of the most evidence-based and can be very useful. So I'm not here to critique the actual therapy, but it's something that is very often offered to people with trauma, particularly if they're in active PTSD and flashbacks, where they're
mm,
in an unsafe way of managing their PTSD. So I'm certainly thinking about my scope there and being careful with that. But in the moment, how can I keep this person safe? So the first thing I want to do is be brave. And I know we've talked about bravery in every single session, but I'm going to keep bringing it back. To be a therapist working with chronic pain means to acknowledge your own bravery, right? We're going to have to be in uncomfortable situations where we may be a bit afraid and still do things, right? That's bravery. So being brave enough to acknowledge, I can see that you're having a difficult moment right now. Yeah. And sometimes I might even just label their non-verbal stuff. So because they may be disassociating
mm,
from their own body. So I might say, I can see that you're holding your body very stiff, that you're no longer making eye contact with me, that you're sweating, that I might start labeling just what I see just to help them
mm,
find that connection with their own body. Oh yeah, no, I am doing that. Is that, this is an opportunity for us to just slow down, right? I want to create as much safety for that person. And the best way that I'm going to do that is by modifying my language. So I'm going to slow down, right? Because I'm
mm,
fast. So I'm going to slow down. I'm going to manage my own energy. I'm going to anchor myself down because what we know is that people experiencing panic disorders or anxiety co-regulate quite commonly. So I'm going to want to be the best model of co-regulation I can be for that person if I'm in the room. So I'm going to slow my breathing. I'm going to
mm,
imagine my body is very heavy. I'm going to let everything sink down into my chair and I'm going to connect very much to what it is in the here and the now.
mm,
We are here in this moment. We are in this room. We are in the OLVG. We are on the fourth floor. It is the 2nd of September. My name is Laura. I'm going to bring this person into this moment as much as I can and then give them the time and the space to wait, to see where we go. Can you
mm,
be here? Can you feel the skin on your fingertips? Can you feel the weight of your hands on your thighs? Can you feel your feet on the floor?
mm,
Yes, we've gone somewhere in the past. That's okay. That's your mind trying to protect you. We've triggered something, but you are here in this moment and you are safe. Yeah. That's
mm,
how I'm going to start building in safe anchors. But I'm also modeling to that person, hey, when you have these moments, do you know what you can find? You can find your own body, you can find the present moment, you can find your sense of self. Yeah. And so it's
mm,
it's not only a way of creating a safe space for this person, but it's also a way of modeling how to be. And then I'm going to have a conversation. Have you been treated for trauma by a psychotherapist? I think this is a sign that this is a really good moment for us to try and bring that in to our team to work with us. Because look, when we work with your pain, we trigger all of this psychological distress. You
mm,
deserve a multidisciplinary approach to your care. You have a right to high value multidisciplinary care, even though it's scary. And I'm going to walk that with you. We're going to help find you a good
mm,
clinician. We're going to slow down in our pain management now. I'm not going to keep flooding you and exposing you in this moment because that's not safe. We're going to slow down. What can we do together that doesn't trigger all of this? Not because I'm afraid of it, but because I want to make sure you are the safest you can
mm,
be as you go through that. Because I
mm,
want you to do well, because you deserve
mm,
that as another human
mm.
being that's been through a lot.
I certainly felt that, Laura. I'm sure other people in the audience did too. To have that
Mm,
modelled, it's very powerful. Thank you.
It can
Okay.
be.
Yeah.
Yeah.
Oh, wonderful. Thank you. So
Can I speed up
just
now?
yeah, sorry. I am sorry. We need to just crack on a little bit. Thank you. So many clinicians worry about opening a can of worms when they start addressing psychological factors. And I think you've touched on this already, about being brave. But how do you manage this fear while still being psychologically informed?
The thing that I remember is that this is just normal human stuff, right? I've experienced psychological factors just as much as that person in front of me, and I'm still here,
Mm,
right? So I just remind myself that this is a human experience. This is not just a patient experience. And I think
mm,
that's the thing I love about ACT is this sort of down withness. Like we're just in it together. It's just that by chance you are on the patient side of this conversation, I'm on the therapist side, but any other moment could be the other way around, you know? So I sort of just remind myself that this is just a human experience. Um, and I guess the other thing I think about is that, I am safe to talk about feelings without feeling like I have to solve it all the time. I think that's where we struggle, you know? It's like see a problem, solve a problem is such a key cultural meme within healthcare. You can see a problem without having to solve it straight away. I know I see loads of my own shit and I'm like, I ain't solving that today. I've got to make tea for the kids and like I know I'm getting in my own way right now, right? Like you don't have to solve it straight away. Sometimes just observing it and being like, oh, look, there's that thing is enough. We don't have to solve everything. Um, and I think the other thing I sort of remind myself is I am not being a psychologist by being like, oh, look, you're sad. That
yeah.
right? Like, first of all, that just shows enormous Dunning-Kruger effect and ignorance on our side of what psychology is. And let's remember, psychology is much bigger. I'm a physio, right? Physio is a baby compared to psychology. Psychology's been around since like the ancient Greeks. Physiotherapists,
Mm,
we're so young, we don't even know what we're doing. We have no idea what our processes or principles are. Like, we're babies compared to psychology, which is just like a mammoth kind of
mm,
topic. So you're not going to accidentally just become a psychologist, right? It takes years to train to be a psychologist. You may be experiencing Dunning-Kruger, which is where I've looked this up so I can do it properly. I looked it up on ChatGPT. Don't come for me. Individuals with limited knowledge in an area lack the metacognitive ability to recognize their own shortcomings, leading them to believe that they are far more competent than they are. Right.
right.
So there's this Dunning-Kruger effect, which might be because I'm talking about feelings, that somehow means I'm a psychologist. It doesn't. It just means you're human and you're able to witness the emotional content that the other person is going
Mm,
through. That's all it
mm,
is. Where we fall, where I think we get into trouble is when we try to work directly on the psychological stuff. So we're now trying to reduce that person's distress, that person's depression. I'm not skilled enough to do that, right? And but I can witness it in the moment and acknowledge its impact on our progress.
mm,
And I think this is where ACT is so helpful because ACT is not trying to directly reduce the problem. We're not explicitly trying to reduce someone's pain. We're trying to
mm,
change their relationship with the pain, which is a very different way of working. So I
mm.
think for me, that's how I sort of hold the line of being psychologically informed, as opposed to working on psychological pathology, right?
Brilliant. Yeah, thank you. I've got a question here from actually came from a member of our audience. They
Mhm,
messaged me before the session today, and it's so pertinent, and it's just the right time to ask this question.
mhm.
And it is, where do you start? Where do you go, or what do you do to get yourself trained in psychologically informed practice? And it probably isn't the answer that you're hoping for.
Yeah, I mean, go to therapy. It's the first thing I would, right? Experience the process, know what the other side
Mm,
is doing, and know how hard it is actually to go through
mm,
cognitive and behavioral change. I mean, I think I've been saying this for the last 10 years. I have a psychologist that I see regularly for my own shit, right? Because I'm a human and I'm 40,
Mm,
which means I've collected stuff over the years so that I can do my job better, right? It's important. I
mm,
also have a psychology mentor who supports me with my own practice to help me navigate that because I
mm,
walk the line very close now, right? Because I've been
mm,
psychologically informed for so long. So, but I think if you're going to start, I think one thing I would start with is definitely like reflecting on your own process. Why have you become a therapist? Who are you here to fix, right?
mm,
What are you here to, what is the reason that you got into therapy? I think that's the first place I would go. Then I would start thinking about what type of psychotherapy do you want to be informed by? Because, like I say, psychology is a huge topic. There are multiple frameworks, right? Not just acceptance and commitment therapy, which is part of the CBT family, right?
mm,
It's a family, cognitive and behavioral approaches is a family of therapeutic frameworks that are all working on this kind of process of transformation. But you could also be thinking about, like, so try and figure out which one you want to be informed by. I personally am informed by acceptance and commitment therapy for a reason. It's open source, right? So I don't need to do a very intense CBT training over 2 years, which is really hard. I can just start reading about it and start thinking about first applying it to myself and then looking and observing for moments where it seems to pop up in practice. Because remember, you're not trying to change the
mm,
problem, you're trying to change your relationship with the problem. It's different, yeah? And for that, I always, always, always recommend, I don't get any financial support from this, but I always recommend Russ Harris's book, ACT Made Simple.
mm,
It's a clinical guide. If you've never been introduced to acceptance and commitment therapy before, it explains what the skill sets are that we talk about, the hexaflex. It really explains that we're focusing on psychological flexibility. I think I still go back to this, and I've had this now for about, I think, maybe 15 years. I still
mm.
go back to this. I'm like, oh yeah, that was it. That was the point. The other thing I'd say, if you're
Great.
a physiotherapist, this is a nice book, Psychologically Informed Physio. It's got some really nice tips and chapters in there about managing anxiety in the clinic. I mean, it uses the yellow flag system, so that's nice. And if you haven't read Science in Suffering by Professor Patwell, please go and read it because he talks very much about how the psychological aspect can be part of how we come out of pain, learning that pain is part of our everyday life. It's a human
Mm.
experience. I think
Thank
these
you,
are
Laura.
three books I would say to start with.
Thank you. We will drop Luke the links to those details in the show notes.
Mhm.
Um, so if we're going to wrap up now, and we're just going to talk about a little bit about Laura's unique approach to delivering explained pain. I hope that today's given you a flavour of the kind of breadth and depth that Laura brings into all of her teaching, or of her knowledge that she brings into all of her teaching. So, if you might be interested in doing a deeper dive with Laura on one of her Explain Pain courses, where she brings in all of these threads into a fantastic either 2 day or 4 week experience, then Laura's just going to give you a little flavor of what you might expect from an Explain Pain course with her. So, how do these psychologically informed principles integrate into your Explain Pain course, Laura?
Yeah, so I think for me, I focus mostly on what is it like to have your belief system challenged and to be invited to update that. Like, where is the resistance? Why might we need to slow down with someone? How do we bring a compassionate approach to that and again, I keep saying it over and over again, but pain neuroscience education is a therapeutic choice. It's not just something we give everybody. So how do we make that therapeutic choice? How
Mm,
do we stay empowered in our profession as clinicians in that moment when we feel a bit out of sort of like what's the word, overwhelmed ourselves, right?
Mm,
So how come so that's sort of the thing that I focus on when I think about learning and I think about updating. And then I still focus very much on the sort of the target principles of conceptual change in explain pain. I don't think that EP is a place for you to learn the neuroscience of pain. I think that is something that you should be focusing on as pain interested clinicians. And that's why there are things like Le Pub Scientifique, that's why there are things like Pain Geeks, that's why there are things like the
mm,
old blog Body and Mind, which you can still access. And like I think that pain neuroscience pain neuroscience education is about the pedagogical approach, which is what Dave always wanted Explain Pain to focus on, which is why I love
mm,
the way he teaches. He is modeling how to update somebody's knowledge about pain,
mm.
not creating a strict neuroscience curriculum. I think that's the
100%.
thing. And the neuroscience of pain is moving on all the time. So if we're working in pain and we're pain specialists, like we're going to have to be flexible with that knowledge and move on with it as well. So I
Mm,
think for me, many of the target concepts within EP are still very relevant. Some of them I think we need to update, but that's part
yeah.
of the process. And that's what I mean. We're moving beyond this idea of scripts and into sort of authentic, flexible, in the
Wow.
moment therapeutic work.
Mm,
Yeah.
absolutely amazing, Laura. Thank you so much. So moving beyond scripts to authentic, psychologically informed therapeutic relationships. If you're
Yeah.
interested in a bit of that and you want to spend either 4 weeks with this woman online or 2 days with her in Dublin,
God
then
help
get
you.
yourself onto the Noi Group website and check out her courses. She is amazing. And I know everybody in the audience, like literally, there's been like a stunned silence listening to you. Thank you so much, Laura,
Oh,
for sharing your
thank you for all the hearts. Thank you, guys.
Thank you. And thank you everyone for joining this clinical discussion. If you want to watch more of these with Laura or with our other amazing Noi Group teachers, head on over to the clinical discussion YouTube channel. There's 40 or 50 up there now. And if you want to get in touch more directly with Noi teachers, then get yourself into the clinical discussion Facebook group, and David Bolton will be there waiting to support and guide you. Thank you so much. We'll be back in a couple of weeks with another session with Laura, which I'm already
Yay.
excited for. Thanks again, everybody. Enjoy the rest of your day, your evening, or if you're just getting up. Enjoy the session. And if you're watching on catch up, thank you so much as well. Take care, everyone.
Thanks.
Bye.
Bye.